Hello everybody, my name's Annibal. I'm the Director of Operations at the National Centre for Rural Health and Care, but a number of RSN members may know me because I've been involved in a whole range of different bits of work for the RSN over the years, and in its new setting of not being able to meet face to face, I'm pleased to be part and parcel of its approach to the 2020 conference. But I'm talking to you today wearing my hat as the key director figure within the National Centre for Rural Health and Care about something very exciting that we've been doing in relation to our mission. And our mission really is to make people aware of the challenges of delivering rural health and care, and to make sure that we network into a whole range of policy environments where we can make a difference. And to do that, amongst the normal lobbying approaches that one would take, we've been able to establish a parliamentary inquiry. And that parliamentary inquiry has given us access to a whole range of people, both as expert witnesses, but also as policymakers, that I think without that particular faculty, we wouldn't have been able to influence and get involved in. So it's given us a really rich and detailed opportunity to further our objectives. And it's also been exciting because we've been supported really ably by some very significant people in doing it. So we've been working with a co-chair arrangement. Two people have been involved in the process of chairing it. Anne-Marie Morris MP, who is a Devon-based MP, and the Bishop of London. And you might well ask why the Bishop of London, because London isn't necessarily a very rural place, but the Bishop of London was, in her former life, the chief nurse. And before that was a bishop in Crediton in Devon. So she's got a real feel for and passion about rural health and care. And those two individuals, supported by the National Centre, and whilst I've had a role in relation to that, our chair, Richard Parish, who's got a real background in public health, has been the key player, have run a series of sessions to actually say, well, what are the key issues around rural health and care, and how should we address them? And these sessions previously were held in Parliament, in different committee rooms, but latterly have been held by this sort of facility on Zoom. And they've built up to a significant core of information, which there are two sessions still to run. But when they're completed just before Christmas, will give us the opportunity then to begin writing up the narrative that's come out of those discussions. And then there'll be a report in probably early February that sets out the learning and the outcomes from the work. And that won't just be written by the Secretariat for the National Centre and overseen by the people I've mentioned who've been involved in leading the governance of it all, but we're also working very closely with Nuffield Trust, and they've very kindly offered to act as a critical friend through the process. And we're thrilled about that because they're one of the premier think tanks in England and globally, actually, on a whole raft of health issues, but with a particular focus and interest in rural. So the sessions themselves have tended to have 4 or 5 witnesses. They've come along and they've been able to make a presentation, and then there's been a debate and a discussion about the issues that they've run through. And I just wanted to give you a flavour of some of the things that people have talked about. So interestingly, the first session was about that big question, which is at the forefront of everybody that's interested in rural issues, which is, what does rural mean? And we had a range of different speakers there, including the head of statistics from DEFRA, and some people on the ground who are responsible for administering services over rural geographies. And the outcome of that was really to establish that in many senses, because it's a big and to an extent one-size-fits-all organisation, the NHS doesn't have a good handle on rural. And in fact, one of the catchphrases that's used in terms of the rural funding formula is to describe places as unavoidably small due to the challenge of remoteness, which is probably the most convoluted and not positive way of thinking about rural places I've ever come across in 30 years of being involved in rural. So coming out of that first piece was a clear sense that we need to do more to properly kind of understand rural as a concept and to get it to get into the bloodstream of people who plan services from the NHS at a big picture level, but down to much smaller levels of organisations. We've also looked as part and parcel of this process at systems, by which I mean how are different elements of health and care organised, and at the core of that discussion has been a recognition of the importance of social care. So we do have this ongoing unhelpful split in England, where local authorities have responsibility for the social care agenda, and then you've got the NHS that's responsible for the health agenda. But actually, it's not that binary, and we discovered, some really important roles played by the voluntary and community sector and the private sector. And in addition to thinking about the roles that those different players had, we also established really that there were some key challenges around rural service delivery that some of that systems development didn't fully get to grips with. So when we started the inquiry, we were in an agenda where sustainability and transformation partnerships were the big thing, and now we've moved to the creation of these things called integrated care systems. And there were a number of speakers who talked about the importance that ICSs, when they're fully established, and some are and some are making, some partnerships are making a transition to them, should make sure that they've got the right governance in place to ensure that small rural communities and small rural stakeholders are represented in some very big planning geographies. And there are some new elements of the long-term plan which is driving this, which is the big plan for the NHS, which is driving this agenda around integrated care systems that we also found really interesting to talk about, one of which is these things called primary care networks. So these are clusters of GP surgeries working together to look at service delivery, particularly around preventing poor health. And again, there are some particular issues about making sure they work well in rural settings. So that was really quite interesting. We've had a session that's looked at training and development, and that's identified some real issues that suggest actually at the absolute heart of the challenge of delivering health and care in rural settings is this workforce agenda, that people are attracted to the bright city lights. They don't necessarily think they'll have the same kind of career development opportunities if they're working in a rural milieu, and they don't, in some cases, like the idea of a lot of travel, which is another key component if you're, for example, a GP or somebody like that working in a rural setting. So that whole piece was really interesting, and we discovered really that most of the training that takes place, and we had some comparators in other big rural places like Australia and the USA and elsewhere, which I know their rural is bigger, but that probably is why it drives the difference, which suggested that we could do a lot more to have tailored courses and tailored training and tailored clinical placements and continuing professional development even for people that was themed around rural as well as the kind of clinical professions as a spatial issue, because in those other countries, immersing people in rural delivery makes a big difference in terms of their interest in it and the ability to recruit to it. So that was a really interesting piece that led us to reflect in the importance of those issues. We also ran a couple of sessions on different types of rural, and the one on coastal was particularly interesting because there are some particular issues when you put coastal settings and rural settings together. You almost get a double whammy. Rural settlements are, by definition, at the end of the line. They're in a terminus position in that, if you go any further, you get your feet wet. So it's difficult, A, for people to get in and out of those settlements, and then quite often they have a big sparse rural hinterland. And I suppose the most extreme example of that we had evidence from was from the Isle of Wight, where the whole place is surrounded by water, and there, the relatively small hospital trust that runs the acute settings got very strange challenges in trying to provide a uniform service that you'd recognise in any part of England. So, around some of their neonatal care, you can have situations where you've got dedicated specialist staff but no patients because there's such a small volume of need. But then if that need spikes, you can find that you haven't actually got the capacity because it's only a very small population base to deal with the challenges. And there's no real process at the moment that properly reflects in the way that policy is made some of those very particular challenges around rural and coastal places. And so that's going to feed into our recommendations. We had a whole session on broader workforce issues and the whole role and function of volunteers, and this really interesting initiative called Helpforce that's been developed, and which is seen by the NHS as a really important means of giving more recognition to the value of volunteers. And from our point of view, the idea of sustaining volunteers who make a big difference to rural health and care because they fill in some of the gaps and some of the holes in provision is really important. We had a look at professional training and development, and what came out of that was the fact that we have a number of what we might call shoulder professions. So people's traditional view of health and care is that you've got a GP and then you've got a hospital, and if you're poorly, you can see the GP and then you might end up in the hospital. We now have a whole range of other people who provide support. So we have advanced nurse practitioners who are able to take you 9/10 of the way you might go down with a GP. We have prescribing pharmacists. And what we discovered was that these roles could make a real difference to what was on offer to people in terms of health and care in rural settings, where sparsity means that you don't have so many of your traditional health practitioners. And so there's some really interesting things for us to reflect back from our work in relation to those issues. And then COVID came along, and that's changed the dialogue really in terms of what we've been looking at, and it's made the whole thing very interesting in relation to thinking about technology. So I think in rural settings, people can sometimes fall into the trap of seeing technology as the end itself and not the means, by which I mean if we concentrate too much on the cleverness of a technical innovation, we miss the fact that actually the whole reason we're interested in it is because somebody's got some issues to do with their health, and it's the issues to do with their health that are most important. And we heard some really compelling evidence from Airedale Trust, which is a national lead in a rural setting of e-medicine, about how if it's done well, you really need to be patient-centred and owned by the patient. We also heard how some of the derogations around record management as part of COVID had enabled e-activities to be much more successful by freeing up access online to information and data, and the general feeling that actually more could be done to preserve some of that good stuff once we get on top of the COVID pandemic as a kind of positive unintended consequence of COVID and the way that's played. We've most recently been engaged in discussions around adult social care and mental health in rural settings and how they're dealt with. And the whole adult social care piece is kind of very complicated and under huge financial pressure, but we heard some fascinating examples of things that have been done to tackle that. We heard a really exciting narrative from an organisation called Community Catalysts based in Harrogate, who were able to explain to us how they've worked in a number of settings across the whole of England, a big cluster, for example, in Somerset, to enable people, instead of being just salaried or even very pathetic paid care workers, to become self-employed and to navigate that around the requirements of the CQC in a way that enables them to provide care that they direct, gives them through a transition from being a worker to being an entrepreneur, much more esteem and control over their destiny, and which generates jobs in deep rural settings. And that also means, because the carers are closer to the people they're serving, it reduces the carbon footprint of that whole process of care. So that was absolutely brilliant and engaging, and is going to roll out further. And some evaluation has been done in relation to that by the New Economics Foundation. And I would advise people, if they want to know more, to get in touch, because we can make that available to look at. We also heard about how centres, walk-in centres and community hubs have been repurposed to provide something which is a more locally focused, bite-sized version of your traditional old-fashioned model of a cottage hospital. And that was really, really interesting to hear about, in terms of the whole range of challenges in growing the adult social care provision and support that was available, and also the idea that care homes could become not just places where vulnerable older people live, but places that were community hubs that could provide a whole range of other services to the community in rural settings, and therefore reach out and build a level of inclusiveness and engagement that wouldn't traditionally exist. So some fascinating stuff around that. And then in terms of mental health, a brilliant example from an initiative in Scotland called Support in Mind, which has developed a national rural mental health framework and strategy. And I think it's almost impossible to think that there wouldn't be value in replicating that in England, because I think it could make a huge difference. So that's going to become one of the campaigning issues that we've got coming out of things. So we've got 3 sessions left to have. We've got one that'll be about blue light and emergency services, and I think that'll be a fascinating discussion. We've got some key evidence lined up for that, including people from first responder schemes, which are voluntary schemes that deploy people out of their day job to respond quickly in deep rural settings to accidents and other problems. And there's a particular rural flavour about those, if they work well, really adding value to the statutory infrastructure. And then we've got an international session that we're planning as well, with potentially speakers from Australia. And there's a whole cluster in developing countries of people who've not been held up by regulation and bureaucracy, that have developed really exciting things very quickly. And we're hoping that we might have some people from India and Pakistan talking to us about some of the things that have happened there as part of that. And then we've got a final session in December to pull all this together. And then the write-up, as I said, in January, February. So a lot of work's been done. There's a lot more to do, but it's been a really interesting journey. And I think what it will do is create some new critical mass for an enhanced debate and discussion about how we actually address the key challenges that rural places face, and really start to get to grips with an NHS which at the moment is, for want of a better term, a bit place blind. So I hope that gives you a good flavour of what we're about. I'm delighted for the opportunity to spread the message via the RSN. And if you'd like to know more, I'd be very happy to talk to you in person. Thank you very much.